ladies and gentlemen, and we welcome you back to our peer-led neuroscience training series for Ugandan psychiatrists and trainees. We are now in week 2 of 6, and this is the week in which we are exploring a subject that actually deeply affects us at, work, in our communities, and sometimes even our colleagues, and that is substance use disorders and other addictions. So this is the first of 3 episodes this week that we will have today, tomorrow, and Thursday. And all of them will be beginning at 7 p.m. and ending at 8 p.m. sharp, using this exact same Zoom link that you have used to join this discussion. So each session that we are going to have is actually going to be building on the last session. And today, Dr. Raymond Mogume, who is our presenter, is going to be telling us more about what substance use disorders are, what addictions, and he will take us a bit deeper into the epidemiology and other aspects, as we shall find out over time. So we have a lot to unpack this time. Our presenter, Dr. Raymond, is one of our own. He's a newly minted psychiatrist from the Department of Psychiatry of Makerere University College of Health Sciences, and is a passionate clinician whose work continues to inspire many of us. So before we begin, let us have just a few quick reminders. First of all, let us note that this is part of an ongoing 6-week peer-led training series. So for the next 6 weeks, we shall be together with you every Tuesday, Wednesday, and Thursday. And we are also requesting you to please fill in the short poll, which we are going to display at the end of Dr. Mugume's session, because it helps us to better understand whether actually we are delivering content that is adding value to you as a person. So we request you to settle in, open your minds, and get ready to engage. My name is Dr. Muyanga Andrew Mark, and I'll be your moderator for tonight. So Dr. Raymond, I can see you are on. You can start sharing your slides and take us away. Thank you.
Good morning, viewers. Good evening, viewers. Pleasure to welcome you to our session today. Thank you for the introduction, Mark, and I'll go straight away to what the discussion is about today. Today we are talking about substance use disorders and other addictions, and we'll delve into the history, the definition, and the diagnosis to start the series for this week. The language of addiction is very complex, and it roots partly from the ancient Roman language, which was related on the idea of seeking answers from the gods, known as taking auspices. But a more technical and legal word, addictio, referred to the judicial act in the ancient Rome, where a person, like a debtor, was given over and made the slave to their creditor. And in that event, a debt would not be paid, e.g. gambling debts. But over time, this term, of course, has become adapted and less specific, including giving in to the ruinous desires of the body and to become enslaved by the vice. And hence, throughout the centuries, and in English, this language of addiction has been flawed and sometimes used positively to mean attachment or devotion. Like in religious contexts, you hear people say, I'm addicted to my religion, I'm addicted to God. But sometimes it can also mean negatively. And in most times when people use addiction, usually, historically, this is dependent on the object of addiction, considered either a good decision or a misguided choice. What we need to know is that addiction has been characterized by the compulsion to seek or take a substance or engage in a behavior. And the loss of control relating to that and also it has been related to the loss of control relating to that substance. Addiction can be defined as a state of dependency produced by both the habitual taking of the drugs or the regularly engaging in certain activities, as we shall see the types of addiction. And it should be known as well that it's possible to become addicted to almost anything and everything. But what is more prominent is that when we talk about addiction, people usually talk about or think about substances such as heroin, marijuana, alcohol, cannabis, tobacco, among others. One of the new things is that also gambling, which usually is about behavior, is also one of the things that you can get addicted to, but sometimes also people get addicted to work, where you become obsessed with work to the extent that other aspects of your life are affected, maybe your family, your friends, among others. The internet as well, where you spend hours surfing the internet or gaming, to the detriment of the other aspects of your life. The other one is shopping. The high from buying unnecessary things can be followed by feelings of guilt and shame, to mention. We have types of addiction. Addiction can be divided into two. We have the substance use disorders, which is really addiction to psychoactive substances. And then we also have behavior addictions, behaviors that develop as a result of specific repetitive, rewarding, and reinforcing behaviors. So individuals who usually have these substance use disorders, they usually continue the use of the substance despite a pattern of adverse consequences. Like they'll be chased after, they'll be told that you've stolen, but they cannot stop. And then the core features of substance use disorders are usually impaired control over taking the drug. We have social impairment. We have risky drug use, either you're using injections, drinking, certain types of or sniffing. And then there are always pharmacological consequences of tolerance and withdrawal. Whereas when we look at behavior addictions, they share many common features with substance use disorders in the disease course, in the presentation, and in the adverse consequences of the addiction. However, the core feature of a behavior addiction is failure to resist an impulse to perform an act, the repetition of which interferes with the individual's functioning. So those are the two core features of the two types of addiction. More definitions, when we talk about dependency, we usually mean the physical, the psychological effects produced by the habitual taking of a certain drug, which is usually characterized by compulsion and the need to continue taking the drug. And under it, we have two types of dependency. We have the physical dependency and we also have the psychological dependency. With physical dependency is that once you withdraw from a drug, you have specific withdrawal symptoms, okay? And then for the psychological dependency, we usually refer to the repeated use of the drug induces reliance on it for a state of well-being and contentment, but there are no physical withdrawal symptoms if the use of the drug is stopped. So usually in psychological dependency, people usually use the drug to either feel good, to function, and to get hold, what they usually say, that hold their shit together in that case. And then we have tolerance, which is the reduction or loss of the normal response to a drug or other substance or activity. It can be a medicine or it can be gambling that normally provokes an effect in the body. So let's say someone started with one drink and it used to get them tipsy. tolerance would be if you find that you need maybe 2 to 3 bottles or more to just get the same effect that 1 bottle would give you. Then we have what we call withdrawal symptoms, and usually this is usually they result from physical dependency, which produces symptoms when the administration of the substance or participation in the activity is ceased abruptly. And the ones that we usually know or we have observed in one way or the other, we have sweating, vomiting, tremors, among others. Addiction versus dependency. We should know that addiction is not the same as dependency. And physicians and patients often have argued for a clear definition of the two and in line with the changes. So this was with the ICD criteria and in line with the changes in the DSM. In the DSM-3 to 4, it's where we had dependency. The concept of substance dependency was introduced in the DSM-3. That was in the 1980s as an alternative term to addiction. However, broadly, dependency can occur with many medicines that are not addictive, e.g. insulin and analgesics, due to their chronic use being confused with addiction. So tolerance and withdrawal, which previously defined dependence as sometimes a normal response to CNS active medications, and hence do not necessarily indicate addiction. To remedy this perceived confusion between addiction and dependency, in the construction of the DSM-5, changes were made to attempt to clarify the diagnosis of substance use disorders and other addictions. Hence, the separate categories of substance abuse, substance dependency were all removed in the favor of the new substance use disorder category. So that is very important to clarify. The historic use of psychoactive substances. It has been said that psychoactive substances were used for spiritual use. To mention were the psychedelic mushrooms with various active substances such as psilocybin and the musumo have been long used by the shamans to induce dissociative states. But they have also been used for medicinal use, like the opium preparations. Until recent times, historically regarded as safe and have in the past been recommended for various conditions, including melancholia and excessive crying in children. But they have also been used for recreational use, and this is really more known. We have alcohol, nicotine, caffeine are widely used throughout the world and have helped to shape the high street from pubs to coffee shops and tea houses. And honestly, this is, I think, more common. How bad is this subject? How bad are the substance use disorders and other addictions? The prevalence of alcohol use and alcohol use disorders is that by the World Health Organization, World Mental Health surveys, the mean lifetime prevalence of alcohol use was at 80%, which is high. And the prevalence of DSM-4 alcohol use disorder was at, the lifetime prevalence was at 8.6 and the 12-month prevalence was at 2.2. But most importantly, what we need to know is that the prevalence of alcohol use and alcohol use disorder is high overall, with a large variation worldwide, as we shall see probably tomorrow. This is the total alcohol per capita consumption as of 2016, but when I checked today, for 2025, Uganda is at 6.5 liters per capita, as opposed to what used to be, what has been circulating around. I know what has been circulating around was, I think, at 12 liters. But as you can see, as of 2016, Romania was highest at 29.6 liters. And so that again emphasizes the subject that the prevalence of alcohol consumption is high and varies considerably around the globe. Then when we look at, this was males, then when we look at females, again, aged 15 years and above, Ukraine still is at its best, where it has 15.38 liters per capita, and Iran is the least, as you can see in this diagram. And that is the variation that we are talking about in this case. We are singling out alcohol because, again, we have lived with it. It has been here for generations, and it will be here for more generations. The pharmacology of these drugs of abuse, we have what we call, they are really dependent on where they work, especially the receptors and the neurotransmitters they do sometimes compete with at the receptor level, or they modulate in one or the other. So when you look at the sedatives, these ones usually work at the GABA receptor, GABA receptor agonists. We have alcohol, which works on GABA A and GABA B receptors, but also it also works on the N-methyl, the NMDA receptor as an antagonist. Benzodiazepines also work at the GABA A receptor, and we shall look probably tomorrow on the neurobiology on how they actually really work. And the benzodiazepines are positive allosteric modulators. They just attach almost next to, on one of the subunits of the GABA A receptor. And then the gamma hydroxybutyrate, the GHB, which works on GABA B and the GHB receptors. Then we have baclofen, which also works on GABA B receptor. Then we have the opioid, we have those that work on the opioid receptors. Mostly opioids, they work on the mu opioid receptors as agonists. And we shall get to know what are some of the opioids that are within our surroundings in the next coming presentation. We have glutamate receptor antagonists. We have ketamine, phencyclidine. Usually these ones give you kind of a dissociative state, and we shall again see that how that goes. We have stimulants, which usually work on either dopamine or noradrenaline. We have cocaine, which is an inhibitor for both dopamine and noradrenaline. And then we have the amphetamines, which are also inhibitors. The amphetamines include the methylphenidate, the methylamphetamine, among others. Then we have acetylcholine agonists like tobacco or nicotine that work on, that are agonists on the nicotine acetylcholine receptors. We have others that have not been classified in the first two, like the cannabinoid receptor agonists, where we have the cannabis working on the cannabinoid receptor 1 as an agonist. Then we have serotonin receptor agonists as well, where we have the LSD, the DMT, and then and also those that enhance both serotonin and dopamine, such as MDMA or ecstasy. We shall get to know some of these drugs properly and maybe their street names, so that when we hear then street names, we don't think that they mean something else. There have been theories that have been put forth on why do people get addicted to drugs, either behavior addiction or substance use. And some of the theories that are known include the psychomotor stimulant theory. Some research indicates that the mesocortical limbic dopamine system is usually very involved in the psychomotor activation and reinforcement of certain drugs. So we will again look into the neurobiology and see which of the dopamine pathways is mostly implicated. But to mention, the mesocortical limbic system is very, very indicated or has been well researched about. We have the incentive sensitization theory, which really states that drugs are thought to activate the neural systems that have involved to make animals approach salient stimuli that are key for survival, excessively amplifying the wanting. What does that theory talk about? It literally means that these drugs have, so we know that sometimes the best example would be sometimes, let's say you've gone into, there's this, for the guys, there's this lady you want to talk to, but then for some reason you're always not, you don't have your confidence right. So taking alcohol, sometimes you've heard that people or the men would actually have that confidence to go in. So that is the incentive sensitization theory, how it applies. Then we have the aberrant learning theory, where they say that the repeated exposure to drugs actually increases your risk of using, but also it kind of modulates the neurosystems that normally control responses to non-drug cues. So the repeated exposure can be that from where you grew up from up to where you've been like exposed to drugs of all sorts, alcohol among others. It kind of accentuates the responsiveness to those drug cues that even when you would want to stop, there's already modulation of these neurosystems that usually would help you to control those responses to non-drug cues, okay? Then we have the frontostriatal dysfunction theory, which states that people with substance use disorders often display poor impulse control. And some have argued that the alterations in the limbic and the cortical circuitry in response to drug exposure usually lead to this pathological response to the drugs. And in the end, they downregulate the inhibitory executive control systems. We also have the endorphin theory, which is that drugs and behaviors such as gambling release endorphins. There's like you're accelerated, you feel very happy, and hence that can lead to a chemical dependency in the brain. The other theory that we have probably heard of is the gateway theory, where they talk about, it's not here, but the gateway theory states that certain drugs, the use of certain drugs kind of opens the way the use of other drugs. And the most implicated drugs in that gateway theory is usually alcohol and smoking. That once you begin them, it's like a gateway to use other more, let me call them sophisticated drugs, like the marijuana, the cocaine, the heroin, the fentanyl, among others. Addiction, how does addiction begin? Some elements of this addiction, there's what we call the addiction pathway. And some of these elements, from compulsions to taking a substance, the loss of control in limiting that substance, are really shown in this diagram. That it starts as a choice, right? Maybe you have friends who because you want to fit in the group, you try out, okay? You're given that choice. Okay, you try out if you want to try it. Maybe you take this substance, you were angry, but then when you took the substance, you feel different, right? Or maybe you were very anxious when you took the substance, it reduced that discomfort. That becomes a choice, right? Now, what that leads to, it leads to that substance preoccupation, depending again on the appetite that you have with the drug, how it made you feel different. Every time that you feel angry, most likely you'll be preoccupied with using a substance. If you feel anxious at the beginning, if you took the substance, it made you comfortable. Either you smoked, either you drank alcohol, or you did weed, and it made you very comfortable, you most likely get that. But what happens is that some of these drugs, you will get that temporary satisfaction. Let's say you were anxious, you will be calm. Let's say you were sad, you were feeling low, your mood was low. When you took the substance, you were up in the air, your energies, you had the vibes, you were the life party. That will be the temporary satisfaction. But also, with it comes withdrawal, right? Certain drugs, you just need one exposure, one bit of an exposure, and you already be with withdrawals, and we shall see what kind of those drugs would give you that, okay? And then you get into loss of control, where you're impulsive, you're compelled, or you're compulsive, and those two usually go together. And this, in a way, gets into a habit formation. Once there is loss of control, you have a habit formation, and those two will guide that cycle. With habit formation, of course, withdrawal can either give you the habit formation, or habit formation can give you withdrawal. And then that's how the habit is formed. So it's usually from a choice, and that leads to a habit. And once you get into that habit, you will need professional help to break that habit. Usually they say that the more time that you use to learn to use alcohol is almost the same time you might need to break the habit of using alcohol. What are some of the drivers to addiction? We have what we call the cycle, right? And this cycle is divided into three. You have binge and intoxication, you have withdrawal and negative affect, and then preoccupation and anticipation. So dopamine has been one of the drivers. It's one of the drivers of addiction, but there have been other theories, like I said. So dopamine alone cannot explain everything about addiction, but it's one of the drivers. So stimulants and alcohol activate the dopamine signaling in the brain. And I've told you that tomorrow we shall look at those dopamine pathways. This triggers learning and reward pathways, depending again if you were anxious, if you were angry. These repeated rewards become associated with the stimulus that preceded them, or the cues. If you were angry, you will again go back to the drug to get happy. If you were anxious, so the reward that you get with using the drug is what the brain will associate with the stimulus. So every time every time you're angry, usually the end result will be to try out the drug to get the other effect. Eventually, dopamine pathways respond to these cues rather than the reward itself. So depending, again, the stimulus can be maybe someone has got you angry, or maybe in a difficult position, maybe there's an exam coming up, or maybe there is a big deal coming up and you're anxious. So some of these dopamine pathways start to respond to the cues rather than the reward itself, rather than that feeling of laxity, of your calm. The dopamine pathways get related with the cues of, like, if someone is going to get you, if you're anticipating to get angry, you might start taking, like, as if prophylaxis of sorts. Thus, the environment associated with drug use may elicit surges of dopamine that lead to drug-seeking behaviors and binging of a substance. Whereas dopamine abates after natural rewards, e.g. food. So there are three natural rewards, which is sex, food, and affection. Those are natural. They give you dopamine, right? But these substances usually let's say sex, food, and affection give you a dopamine level of maybe like 150. These drugs usually triple that value, like maybe to 2,000 or 1,000. Okay. Drugs like stimulants, those ones usually double the value of dopamine, or the amount of dopamine that you will experience, and then then you will have no reason of maybe to engage to find food, or to even to be loved, or to involve in sex. All those kind of get abated. And so over time, consumption of these drugs, and we are using stimulants and or alcohol, they later lead to reduced dopamine release, right? Because again, you remember last time Dr. Katama did give us how these neurotransmitters at the presynaptic level, how they are released into the synapse, and then what they do at the postsynaptic level. We have to keep that in mind. But that the continued stimulation of these presynaptic knobs later leads to reduced dopamine release. And hence the dopamine reward system becomes less sensitive to such drug effects. And that's how we develop tolerance and other non-drug rewards. Other non-drug rewards include sex, food, and affection. So individuals can therefore become less motivated by the everyday stimuli. Why someone, let's say, you're always looking forward to engaging with the opposite sex, talking to them or hanging out, you start to become less motivated by such stimuli. You start to be less stimulated maybe to go and watch football, among others. And the long-term effects of dopamine dysregulation result in brain changes and negative emotional states, which are driven by the stress hormones. And this gives you the anti-reward system, which causes a highly dysphoric state in response to drug effects wearing off or withdraw. That's why that sometimes when people just withdraw, and this is the second stage, when they withdraw from the drug, usually they're either sad, they have a low mood, they are isolated, they self-neglect. Like literally, that is what happens with the anti-reward system coming in. Thus, alongside the pull toward the rewards of the drug, there is also a desire to alleviate the discomfort of the after effects. Like I said, some withdrawal effects are usually not nice or appropriate in this case, and so the person is pulled, as is in pulled to find the drug, it's also in a way to kind of alleviate this discomfort that comes with the withdrawal effects. Then dopamine downregulation also occurs in cortical regions, okay, which impairs systems involved in self-regulation and decision-making. And hence, you find that along with changes in glutamate signaling, these brain alterations weaken a person's ability to resist urges or to follow through with decisions. That's why this as we shall see tomorrow in the neurobiology, we shall see, I've taken time, we shall see how that actually really happens. But it is to say that once a person has used the substance, there are brain changes that have happened. And so telling a person to stop is not as easy as it seems on the surface. There is more to than what meets the eye. This is the same again for the stages of opioid addiction, except that there we had dopamine, here we have more of endorphin release. But it's the same science and it's the same course of events. Diagnosis of addiction. In psychiatry, we use, or in neuroscience, we use the Bible of psychiatry, which is usually the Kaplan and Sadok. But in this case, the diagnosis usually is from the history taking thorough, that has to be thorough, and then DSM-5 and the ICD-11 classification. We have about 11 substances that we usually take into consideration. And for substance-related disorders, we look at the problematic pattern of substance use that leads to clinically significant impairment or distress in more than one area, right? Either at home, at work, or at school. And the substance that we focus on, we look at the alcohol, the caffeine, the cannabis, the opioids, the tobacco, the hallucinogens, the sedative, hypnotics or anxiolytics, the stimulants, the inhalants, and the drugs that are not elsewhere classified. Whereas for behavioral addictions, we usually consider the persistent and recurrent problematic gambling behavior leading to clinically significant impairment or distress. And the behavior addiction, so far that we know, is the gambling, but more and more are coming in. We have the internet, we have the shopping, but those ones are not yet well, they do not have a specific criteria within the DSM-5, but we hope maybe in the DSM-6 they will be well articulated. So we have what we call the coding. We have coding of these substance use disorders according to severity. To their severity, we have 0, we have mild, where we look at between 0 to 3, and then from 4 to around 6 is moderate, and then above 7 and above is severe. And this is according to the criteria that we are going to see. So depending on the criteria, if someone has 1 to 3 symptoms, we usually say mild. If they are then 1 to around 6, moderate. Then above 7 of those symptoms, we usually say this is severe, but also and so that is really about the severity coding. So this is the diagnostic criteria of DSM-5, and I said with substance use disorders, we look at the problematic pattern of use of the substance that clinically, that significantly impairs or distresses the person clinically, as manifested by two or more of the following, which occurs within a period of 12 months, that is a year. That the person is taking in, the drug is taken in large amounts over a longer period than intended. There's a persistent desire, which is usually known as the craving, the urge, or that they have previously tried to cut down on the drug, but they have failed. Then a great deal of time is spent in activities necessary to obtain, use, or recover from the drug. People will sell off everything to make sure they can obtain the drug. Then use of the drug, they use, but also there's a lot of time to recover from the drug, which could come with the withdrawal effects. Then, of course, again, we have the craving of the drug. We have the current drug use resulting into failure to fulfill major obligations at work, home, and school. We have continued drug use despite of the persistent or recurrent social or interpersonal problems. We have important activities being given up or reduced because of the drug use. Recurrent drug use in situations where it is physically hazardous. Someone says that they already maybe have an abscess on the injection site, or they are sick. They are telling them their liver is very sick, but yet they continue to use the drug. Then continue drug use despite knowledge of having a persistent or recurring physical or psychological problem pattern, likely to have been caused or exacerbated by the drug, okay? Then tolerance to the drug, and then withdrawal. So if you have 1 to 3, according to the severity coding, would say you have mild substance use disorder. If you have 1 to around 6, that becomes moderate. And then if you have more than 7 of these criteria, then it means that you're in the severe, you have severe substance use disorder. And all of the 3, according to the coding, one judges whether to get you in rehabilitation, to admit you, among others. Then when we look at the criteria for gambling disorder, usually I've said this one is more of the persistent and recurrent problematic gambling behavior, where we look at 4 or more of the following anytime in the 12-month period, leading to a significant impairment or distress clinically. The first criteria is that they needs to gamble with increasing amounts of money in order to achieve the desired excitement. Maybe someone started with 1,000, but they find themselves using now, they went to 5,000, 10,000, small money, salary, the loans they get, everything's being put into gambling, hoping that they will get that jackpot. They're usually restless or irritable when attempting to cut down or stopping the gambling. They'll be very restless. They'll be really anxious. They'll probably be irritable. The third is that has made repeated and successful efforts to control, cut back, or stop gambling. They try maybe for 3 days, but it is always very, like I said, very restless, irritable. They will try to cut down or control. Even you ask them, did you try? They said, I tried, but I couldn't. They're often preoccupied with gambling, whether they're at work or at school, in class or in meetings. They're just looking forward. They are scrolling through those betting companies on which one to do, to bet on. Then often gambles when feeling distressed. Every time they feel helpless, they feel guilty, they feel anxious, they feel depressed, or they think about like the loss they made yesterday, they will still they'll feel very distressed, but then they will go ahead again and gamble. Then after losing money, gambling often returns another day to get even, chasing one's losses. Like they'll be like, hey, yesterday the Indian got hold of me, but today is my day. So that's what criteria 6 means. They like to conceal the extent of involvement with gambling. If you ask them, how much have you really spent? They will say, no, it is very, they will really downplay it. They will say, no, I haven't used a lot of money, but yet the main reason maybe they've been brought by their loved ones is exactly that. And has jeopardized or lost a significant relationship, job. They don't have their social support. Maybe their loved ones have left out because of this gambling problem. They have lost work. Their education is on hold or career opportunity because of gambling. And then they rely on others to provide money to relieve desperate financial situations caused by gambling. And this gambling behavior is not better explained by a manic episode. That is in criterion B. So the first, these are like the categories or the things that you need to look out for in criterion A. And then criterion B is that you have to rule out that all this that I've mentioned is not explained by a manic episode, because we also know that people who have mania usually almost have the same things. They're really extravagant in a way. When we look at the ICD-11 classification, the disorders to substance use disorders, it is not any different from what I've just explained, except that disorders due to substance use and addictive behaviors are mental and behavioral disorders that develop as a result of the use of predominant psychoactive substances, including medications or specific repetitive rewarding and reinforcing behaviors. This is again to give you this classification, but it's not any different. We use ICD-11 classification per everyone who is under the WHO. And then the DSM-5 is really from the American Psychiatric Association. But it is the same, except that when you look at the disorders due to addictive behaviors, we have the gambling disorder, the gaming disorder, secondary impulse control syndrome, and substance-induced impulse control disorders. And so that makes it a little bit of a variety as compared to DSM-5. And again, the disorder, the drugs that we consider in ICD-11: alcohol, synthetic cannabinoids, sedatives, hallucinogens, cannabis stimulants, MDMA, cocaine, opioids, nicotine, caffeine, volatile inhalants, synthetic cathinones, and dissociative drugs have all been identified under ICD-11. So that is what we use for diagnosis. You just need to know the substance and where it falls according to this ICD-11.
Dr. Raymond,
Yes.
I'm requesting that you summarize.
Okay.
Thank you.
So the criteria for substance dependency, according to ICD-11, again, we look at the characteristic features is impaired control over the substance use. The substance use becomes an increasing priority in person's life. And then the physiological features of tolerance, withdrawal symptoms, and the repeated use of the substance to prevent or alleviate the withdrawal symptoms. We have a hierarchy that people don't just wake up and start to be dependent on the drug, right? They start from the base as you go up. So most people begin with no substance use. Most of us are usually at the base, but a few end up at the top, as you can see. no substance use, then there is the low risk of the use, the hazardous substance use. That's where the issue, an episode, that's where we need now to pay attention, where you have hazardous substance use. That's where we should start to caution our patients, but also to increase awareness right from the base. Again, behavior kind of is the reason why we end up being at the top, where we find we have substance dependency. Again, this you can take time to read through from the Neurotorium organization website. We have what we call rating scales. These ones help us to really to follow up with treatment, to also see what the quality of life the person is living, among others. And I'll just give a few. The value of these rating scales can be used to diagnose and classify these alcohol and substance use disorders, as well as psychiatric comorbidity. And some of the factors that we look at in some of these rating scales is the format. Is it structured, semi-structured interviews or questionnaires, the scope, whether clinical research objectives, the reliability, the validity, the convenience, whether it is self-administered or clinician administered, whether it's hard paper or you can be accessed on a computer, and then the training. Some tools require some training prior. We need to know that people usually have substance use disorders, usually are comorbid, and we have what we call the mini international neuropsychiatric interview, which really guides the interviewer through a series of yes or no questions to determine whether the DSM. But again, this can be understood way better if we take interest. And then we have the structured clinical interview for DSM-5 disorders. It just looks at all the disorders, including substance use disorders, and then it also helps it helps the interviewer to judge the best approach to determine the drug class of interest, which is really, really important. The main
Dr. Raymond, kindly summarize. We are
We
out of
have the
time.
audit. Yes, we have the audit, which we usually use in the clinic. It consists of 10 questions, 3 on alcohol consumption, 4 on alcohol-related problems, advanced reactions, and 3 on dependency. And these are the screening instruments that we can use for problematic substance use. We have the DAST, the ASI, which is the Addiction Severity Index, the opioids treatment index, and the severity dependence scale. To summarize, addiction is characterized by the compulsion to seek, take a substance, or engage in a behavior, and the loss of control relating to that substance or behavior. The object of addiction is often a drug or substance, but the person can become addicted to almost anything, as we already said. Addiction is used interchangeably with dependency and substance use disorder, but the terms are not synonymous, are not the same. Once the person begins to use a substance or drug for its pleasurable effects, is at risk of changes to dopamine and glutamate brain chemistry, or the brain changes that I already talked about, that usually create that negative dysphoric state. And we use DSM-5 and ICD-11 to help us diagnose these substance use disorders and addictive behavior disorders. And many scales and questionnaires have been developed for screening and also to aid the diagnosis of substance use disorders. Thank you very much for being part of the presentation. I welcome any questions or any suggestions or additions. Thank you very much.
Oh, wow, wow. Thank you so much, Dr. Raymond Mogume, for the presentation. We really appreciate the time you have put in to simplify the various concepts that you have driven forward. I think I'm requesting Moses kindly put up our poll. We humbly request that please fill in that poll. Give us your opinion on how you think this session has been to help us to improve going forward. Tomorrow, we are still together, same time, same link. So please help us and fill in this poll as we are reading the questions. The first question, Dr. Raymond, is from Emil. I don't want to mispronounce or murder the second name. He has said, hello, everybody. I'm Emil from DRC. I would like to know which indicators to track when piloting a mental health intervention according to the result chain framework. Let me see. According to the result chain framework, if it was possible to proceed by the survey in mental health researchers, what indicators to integrate for the research? Dr. Raymond, that has been sent to you, sir. But what I can say, Dr. Raymond, as you prepare for the second question, I'm sure from Albert Nisima, you can read it, is Emil, we thank you so much for that thoughtful question, and we send greetings to our brothers and sisters from DRC. Certainly, the question you have raised is important, especially when you're talking about monitoring and evaluation frameworks within the context of mental health interventions, especially the results chain approach. But for tonight's session, we are focusing on the neuroscience and the clinical aspects, the epidemiology of substance use and all that, and addiction. So we might not really be able to go into that level of programmatic detail right now. However, I suggest that we flag this question probably for one of the later sessions we are going to have, or we share a follow-up resource where we can discuss the indicators relevant to mental health research more broadly. However, today we are discussing strictly the substance use, talking about the epidemiology, how it comes about, classification, diagnosis. That's what we are focusing on. Dr. Raymond, Herbert Nisima has a question for you. He asked, is there a tool one can use to assess reduced cognition in a person addicted to drugs and substances?
Thank you, Dr. Mianga. Yes, there are tools that have there are tools that have been that you will come across, right? That do assess the severity. You need to assess the severity of how problematic the use of the drug is to the individual too. So some of the tools that I did mention in the presentation, I talked about the addiction severity index, right? Which is a structured clinical interview designed as a standardized diagnostic and evaluative instrument in the field of alcohol and drug abuse. And it looks at the person's three areas: their health, their social, their job, because that's how you can tell if this person is really what quote in quote thinking straight. Okay. We also have the opiate treatment index. For it, it looks at the drug use. It looks at HIV-related risk-taking behavior. It looks at social functioning, criminality, health, and psychological adjustments. Then we have the severity of dependency scale, which is a 5-item questionnaire that is easy to administer, but it measures dependence on a range of different substances. And yes, there are a lot of other tools that you will come across, but because of time again, and not confuse the audience, there are tools that you can use, but the best tool or the best thing that you can do is taking a thorough history of your patient. If the person has used 5 substances, each substance you need to know when they began, how it made them feel before when they took it, what happens when they do not take it, and if they have any withdrawal symptoms, and how that has affected their day-to-day living. That's how you're able to gauge the cognition, and maybe then you can do more sophisticated tools like the Winsler cognitive tool, but sometimes we don't go as that far. We usually refer them to the psychologist to help with checking for cognition at that point. So yes, there are enough tools to help with that NINSIMA.
Thank you so much, Dr. Raymond. Maybe what I could add is we can even just give a list of the general cognitive screening tools. You can think of the Montreal Cognitive Assessment, the so-called MOCA. Then you can think of the mini mental state examination. Then you can go a little further, the Aden-Brooks cognitive examination. Then if you want maybe substance specific tools, you can think of maybe doing a trail making test, which can be excellent for assessing processing speed, mental flexibility, which we know are affected within the context of substance use. You can think of the Stroop color word test, which is going to measure response inhibition, attentional control, which are key domains actually which are affected within the context of substance use. So there is a colleague who has said, Zeimana Emmanuel, thank you for raising this concern. You've asked, you accidentally removed the poll. Please, if you're on a laptop, you can go to move your cursor to the right of the screen. There is a circle with 3 dots. Okay, there's a circle with 3 dots. Simply go and tap polls or quizzes, and the poll will come right back up. Thank you. So let us proceed. Dr. Raymond Nyikirize from Gulu University is asking, could you highlight a few antidotes available for management of common substance use intoxications? I think let me come to the defense of Dr. Raymond Mogume. So this is a 3-day session, colleagues. I know we are excited about getting this knowledge, but I request that we stay together tomorrow and on Thursday. And I think, Dr. Raymond, I think this falls within, is it Thursday or tomorrow? You are the expert on this topic in this case.
It will be Thursday.
Antidotes and management, yes, of overdoses and all that. So that will be Thursday. So Nyikiriza, I'll look for you on Thursday and we shall respond to this question. So Dr. Emmanuel Mwesiga, in relation to the question which had been raised by Emil, I think guided that Emil would need to tell us what impact he would like to achieve, and then work backwards, probably. Botan, thank you for appreciating the work from the team. We shall continue doing the best we can to share whatever knowledge we have. So Herbert Nisima, okay, we have answered you. Thank you. Thank you. Yeah, so Dr. Raymond, we thank you so much for the work. Ladies and gentlemen, thank you so much for sparing time to be with us. Tomorrow and Thursday, we are here, same time, same link. Thank you for joining us and allow us to wish you a lovely night. Please, if you have not finished the poll, please fill it in before logging off. Thank you so much.